This is Mayo Clinic Kids, a podcast from Mayo Clinic where we discuss the latest pediatric research and recommendations to help keep your kids laughing and thriving. I'm Dr. Angela Mackey, a pediatrician with Mayo Clinic in Rochester, Minnesota. This episode, syphilis. Pregnancy comes with a lot of aches and pains. Cramps, swelling, nausea. I could keep going. But something doesn't have to hurt, like a small, painless lesion, for example, to be concerning.
We had a young patient who had just immigrated to the United States seeking obstetric care with us, but her main concern was what she called a sore spot that was not painful in her pelvic region. She said it had been there for a few days, maybe even a few weeks, and she was really concerned because she feared how it might have an impact on her pregnancy and on her baby. We did a full spectrum exam of her pelvic region as well as testing for sexually transmitted infections. Included in that testing was screening for syphilis, herpes, HIV, hepatitis B, hepatitis C, chlamydia, and gonorrhea, and then took a sample. Her results unfortunately showed that she had syphilis. This was her first exposure to it. She had no other symptoms, no fever, no chills, nothing else going on with her.
You might not be used to hearing babies and syphilis in the same sentence. But if you're trying to conceive, expecting, or have a young child, it should be on your radar. Because if a parent has syphilis, they can pass it along to their kid. When this happens, we call it congenital syphilis. In 2022, there were more than 3,700 cases of congenital syphilis in the U.S. And sure, that's not a lot compared to the millions of people in the U.S., but it's more than 10 times the number of cases we had 10 years ago. And this is a disease we know how to cure. So what's going on? Why are we still struggling with a curable disease? And how do you know if you or your child is at risk? This episode, Dr. Yvonne Butler Tobah is going to help us answer all those questions you don't want to have in your Google search history. Yvonne is an OBGYN at Mayo Clinic in Rochester, Minnesota, who specializes in high-risk pregnancies and infectious disease. Well, let's get into a little bit more about the basics of syphilis. Syphilis is something that hopefully most of us learned about in high school, but for most people, it's been a while. So let's do a little refresher. What is syphilis?
Syphilis is a fairly old sexually transmitted infection. It's been around for some time. It was thought to have come from Europe, and then it was initially found among French troops who then brought it to the Americas. It's a type of bacteria that is spread by either sexual contact from a mother to a baby, transfusion, although it's fairly rare now for us to have syphilis-related transfusions. And this can also spread by just physical contact, meaning the lesions are contagious. So if your partner has the typical syphilis lesion and you have exposed skin and touch each other, so you can get it from that as well, whether or not you actually had intercourse. And typically there's a period of time where after you're exposed to it kind of range anywhere from about 3 weeks to 6 months. We call this the incubation period, and that's really just when the bacteria is circulating in your body before you start to have any physical symptoms. The first symptom is what we call a chancre, and that's almost like a painless ulcer that occurs right at the site where the syphilis actually had entered into your body. And then from there, many people go on to develop different stages of syphilis. We divide it into 3 different stages: the primary, secondary, and then tertiary stage. And then there's 2 additional ones. There's one called latent, where you have really no symptoms until we diagnose you with it. And then neurosyphilis, and that's typically the more advanced stage where it starts to affect your brain and your spinal cord.
And interestingly, there's been like some very famous people in history that have thought to have those neurological symptoms that you sometimes see, and hopefully that we don't see much anymore.
Definitely. It's also thought that some very famous leaders in history had alopecia or patchy spots in their head, or they were losing their hair because of syphilis, and oftentimes wore wigs because of that. So one of the reasons wigs became so popular in the old world was because of acquisition of syphilis, unfortunately.
It's a very interesting fact. So most of us are used to hearing about syphilis as an STI or sexually transmitted infection, which generally falls in the realm of adult medicine. But in pediatrics, I would say I do quite a bit of that as well. But how do babies end up with it?
So congenital syphilis is when an expectant parent, so someone who is pregnant and has syphilis, transmits that disease on to the baby they're carrying in utero, so during the pregnancy, at the time of delivery, or shortly after delivery. The vast majority of the times when you're looking at babies, especially who are testing positive for syphilis, it's because they had it from their mom, oftentimes during pregnancy. And in some rare cases, occasionally, if a baby is breastfeeding, if you had an open lesion on mom's body. So if mom has primary syphilis, meaning she was exposed to a partner, has primary syphilis that has never been treated, the chances that her baby may end up with syphilis is as high as 50%. If mom has what's called latent syphilis, and that's the type of syphilis that many of us see now, meaning that patients have no symptoms, she comes in for her prenatal care. As part of what is routinely done, we order all of these sexually transmitted infection labs, including a lab for syphilis, and she ends up being positive. And unfortunately, there isn't a really good way of knowing whether or not this infection happened recently or 3 months ago or 6 months ago. But we typically call that latent syphilis if we think it was within a year and she had no symptoms. The risk of having that mom infect a baby can be as high as 35%. So it's still fairly high whether or not she has symptoms. And unfortunately, there can be lots of complications occurring when syphilis is transmitted from mother to baby during pregnancy.
And you mean complications with the infant specifically, right?
Complications with the infant, but also complications with the pregnancy.
But how common is syphilis in children? Is this something that parents should be actively worried about, or is this relatively uncommon?
So congenital syphilis specifically, although I would still say it's rare, it's increasing, especially in some states. And unfortunately, Minnesota is one of those states where it's increased quite dramatically. And although we're talking about 1,800 cases, say, in the entire state, however, that's still a large jump, especially for a disease of this magnitude that has a cure that we know of and that's been around for such a long time. And that also has the ability for us to test. So we have all the ingredients to be able to prevent syphilis from happening completely if we're testing and making appropriate diagnosis.
So, starting with the basics, syphilis is a bacterial infection that's usually spread by sexual contact. But it can spread just by physical contact with a lesion on someone's body. People who have syphilis may or may not have symptoms, depending on which stage they're in and how long they've had it. And because of that, people might not know they have it. When babies get syphilis, it's usually because they get it from their parent during pregnancy, during delivery, or shortly after birth. The likelihood of a baby contracting syphilis depends on which stage of syphilis the parent has. And while congenital syphilis is still rare, we're seeing more of it than we used to, especially in certain areas. So what's happening there? As you just mentioned, the number of babies born with syphilis is increasing in the United States. Do we know why this has been an increasing trend?
We have some ideas. We think some of it has to do with the lack of prenatal care for some patients. For some people, even when they have prenatal care, they may not have been tested for syphilis. And there are others yet who have prenatal care and are tested positive, but not treated. And there are a variety of reasons why that happens. One is the fact that there are areas in many other large rural regions we call obstetric deserts, meaning that you have this huge swath of land where there are people dwelling and living in these areas, but they have no access to appropriate health care, especially as it relates to obstetric care. They have to travel fairly far for their care. Oftentimes, there's lack of obstetricians, midwives, and other providers who are available to see them. So that's a barrier because you start with someone who's already at a high risk for having multiple conditions, who would like to seek care, who perhaps go out and seeks care, but find out that they have to travel 1-2 hours away, taking time off of their already very limited time they have to seek care. When they get to care, then there's the access issues where either there are times when care is suboptimal, meaning that they get care, but it is not the appropriate recommended care for them. Or there are times when the appropriate care is recommended, but they don't have the resources to move ahead and complete your recommendations. So what do I mean for that? Someone comes in and says, I'm pregnant. I like to be tested for everything. I want to know that I'm healthy. You say, great. I recommend doing these labs. Oh, by the way, I can't do these labs today. You have to schedule an appointment to get these labs done. If they live 2 to 3 hours away, that means oftentimes then that they have to find a way to come back to get those labs done and then come back again to discuss the results. So there's this inadequate care component that is sometimes a huge barrier for patients getting the care they need. And unfortunately, as a result, oftentimes missing the timely diagnosis of conditions like syphilis. There also seems to be an increasing rate of syphilis as the rates of IV drug use becomes an issue. So the two comes hand in hand, right? As the rate of injection drug use increases, those substances may make it a bit more difficult to think as you normally would to make appropriate healthy decisions for yourself. And there also may be more risky sexual behavior taken as a result of that, leading to an increase in folks who are pregnant. In the state of Minnesota, Minnesota has at several times been host to people who are migrating sometimes from war-torn regions, immigrants who maybe have not had opportunities to be tested for these illnesses. And while I am by no means saying that the high rate of syphilis is because of immigrants, what I am saying is that there are times when we see higher positive rates in people who have unfortunately been in war-torn regions around the world where they're immigrating here for a better life, are tested and found out to be positive.
Yeah. And if people are studying over in a new country, like they might not be able to have access to cars or be able to take time off work. They run up against all those barriers to healthcare access that you mentioned. So what are the symptoms of congenital syphilis?
So let's start from prior to delivery. There are certain ultrasound findings before a baby is even born that, along with expectant parents' positive result, would indicate that this baby may have syphilis. One of them is what we call hepatomegaly, or liver that is larger than expected. We can see the baby's liver on ultrasound and measure it. There's another condition where there's too much amniotic fluid around the baby. We call that polyhydramnios. And while we can see this condition with many other viral illnesses, you can also see this in syphilis as well. So I by no means want expectant parents to be really scared that, oh my gosh, I was told I have polyhydramnios. What if I have syphilis? Because that is not the case. But what I am saying is that in some expectant parents who are positive for syphilis, on ultrasound, you may see too much fluid around the baby. You may also see what's called ascites, or fluid that is right under the skin. It's essentially what we would call swelling after delivery, but that tends to be more common in pregnancies that's positive for syphilis. And then after delivery, we typically think of early congenital syphilis versus late congenital syphilis. So early congenital syphilis, some of the common findings would be blood abnormalities like anemia, so the hemoglobin is low, thrombocytopenia, where the platelets, the blood clotting protein, is low. We see neurologic or brain impacts where there's meningitis or inflammation of the lining around the brain. There can be inflammation of the bones. We can see these lesions or patches on the skin and on mucous membranes, and mucous membranes can be anywhere. And again, that large liver, large spleen is also a fairly common finding in kids who are less than 2 years old with syphilis. As they get older, you see more of the bony problems. So there's a condition called frontal bossing. It's this forehead portion of the head that kind of extends outward. And that's one of the classic findings of syphilis in toddlers. They may have syphilis that has an impact on their maxilla. It's short. Their palate, the hard part inside their mouths, there are times when there's a hole in it. There's a time when it has a certain shape. We call it a high arch. This appearance of your teeth, this triangular, very sharp appearance of the teeth, is called a Hutchinson teeth. And then they can have some nerve inflammation that eventually leads to other abnormalities. For example, they can become deaf from having the syphilis infection impact their 8th cranial nerve.
Those are some pretty intense symptoms. And what are the risks for babies infected with syphilis during pregnancy and post-birth?
So when we think about untreated syphilis in the really worst case scenario, she can lose the pregnancy. She can have a stillbirth because the syphilis infection overwhelms the pregnancy. The pregnancy stops developing. The baby is overwhelmingly infected and the baby passes away before she gives birth. Death of the baby can also occur right after delivery because of an overwhelming infection. And there's a number of infant disorders that have been linked to syphilis. The more common ones are deafness. There can be bone deformities. There's some neurologic impairment. It can affect the kidneys, can affect the liver. The same alopecia or hair loss that I talked about earlier that we think occurred in these really famous people can occur with early congenital syphilis as well. It can cause blood abnormalities. There can be skin lesions. And then as the baby grows older, there are, of course, additional complications that can have lifelong impact on these kiddos and how they develop.
Pregnancy is an important time in our lives, full of thrills, unknowns, critical decisions, and big celebrations. You don't have to navigate any of those moments alone. In the book, you'll get the latest expertise from Mayo Clinic specialists, month-by-month chapters, milestones to watch for, and key steps in your prenatal care. Get your copy of Mayo Clinic Guide to a Healthy Pregnancy today at mcpress.mayoclinic.org and use code KIDS for 10% off your order. That's KIDS for 10% off your order.
So there are a handful of reasons congenital syphilis is on the rise. Healthcare access is a big one, but IV drug use is also increasing. Congenital syphilis has a whole laundry list of symptoms. During pregnancy, babies can have enlarged livers, too much amniotic fluid, or fluid under the skin. Post-birth, syphilis can present as abnormalities in the blood, skin, bones, teeth, liver, brain, hair, and other parts of the body. Untreated syphilis is scary stuff. It can result in losing a pregnancy, stillbirth, or different ailments that have lifelong impacts on a kid. That's why testing, treatment, and prevention are so important. What steps can parents-to-be take to avoid unknowingly transmitting syphilis to their babies?
Seeking prenatal care early is one of the most important things you can do once you discover a pregnancy. The state of Minnesota has clear guidelines that anyone who is pregnant should be tested at least twice during the course of her pregnancy for syphilis. And for certain high-risk patients, they should be tested at least 3 times. There is a treatment. There's a definitive treatment, meaning we can treat you and it cures the disease and you're considered done. That is available, and it should be available at any facility that provides medical care. Some patients may say, I barely have insurance, or is it expensive? The short answer is the state of Minnesota, under most circumstances, provides resources so that we can treat patients who are positive for syphilis. So know your status, get tested early, and get tested as often as we need to, especially if you have any concerns of an exposure.
Sometimes the diagnosis of syphilis in an expecting parent can be a little confusing. And part of that gets down to specifically the testing. What are the tests and how do you interpret them?
There's two methods of testing people for syphilis. One is a non-specific method where you're looking at antibodies to a specific protein that is released when a person becomes infected with syphilis. We use that as what we would call a screening test. So if that test comes out positive, it typically doesn't mean that, yes, for sure you have syphilis. It means that there's a possibility you have syphilis, and we move on to a more specific test. The more specific test is actually looking for whether or not you have specific syphilis proteins, not an antibody, but whether or not you have actual evidence of the syphilis bacterium itself. There's a second scenario, though, where you're diagnosed with syphilis, you're treated, and you test positive. Then we have to figure out, is this truly a new positive test? Or is this just positive because you recently had the disease and you were treated already? Again, it's a little bit more complex. I would say the vast majority of the times we are using help from our colleagues in infectious diseases who see this all the time so that we know that we are accurately testing people and giving them confirmed accurate diagnosis of whether or not they have syphilis.
So we know that testing is important, but when should people be looking to get tested?
So with every pregnancy, the American College of Obstetrics and Gynecology recommends testing for many of the major sexually transmitted infections at the beginning of pregnancy and for people who are at high risk mid-pregnancy so that we can confirm that there's nothing that needs to be treated. And then there are times when pregnant folks may have symptoms of concern. They may not know that they've been exposed to something, but perhaps they have a rash or they have a discharge. And really, we should see these sort of symptoms as we would see anything else. You know, if you had a headache, you would want to figure out what's causing that headache and how to treat it. So seeking assistance for testing, and then if positive, getting treated. And this goes beyond pregnancy. So outside of pregnancy, one of the best things you can do for a pregnancy is go into a pregnancy being healthy. So paying attention to your sexual health, making sure that you have a primary care provider. It doesn't necessarily have to be a doctor. It can be a midwife, can be a physician assistant, a nurse practitioner, but someone who's helping you keep tabs of your overall general health and is testing appropriately and screening appropriately for any sexually transmitted infections.
Is it reasonable to expect that a pregnant person going in for their routine prenatal care would automatically get tested for syphilis? Or is that a test that patients need to specifically ask for?
Yes, it is expected that with prenatal care, there will be an offer for testing for sexually transmitted infections, including syphilis. There are standards of care that are recommended by the American College of Obstetrics and Gynecology, which is sort of the academic and governing body that all certified obstetricians and gynecologists look to as it relates to making recommendations for taking care of people who are pregnant. So syphilis is one of the conditions that's recommended, but also HIV, hepatitis B, hepatitis C, chlamydia, gonorrhea. For everyone who enters pregnancy, the recommendation is to test for those conditions. The Centers for Disease Control and Prevention, the CDC, also makes additional guidelines. And in addition to that, we have state-specific guidelines on certain conditions that should be tested for. All three bodies all support the idea that every pregnant individual should be tested for syphilis. I'm also a firm believer that we best serve our patients by providing all of the tools and guidance that they need to advocate for themselves. So I would also highly recommend that folks who are pregnant and going in for care ask, what tests will we do as part of our routine prenatal care? Does it include syphilis? and what happens with the results, et cetera. I think that there's nothing wrong with having that type of conversation. And actually, I would say that most healthcare providers appreciate having that sort of discussion around what is recommended for prenatal care with patients who are pregnant.
So you mentioned that there's an obvious treatment that's readily available for expecting parents or people who may be testing positive for syphilis. What does the treatment for syphilis look like in babies and children?
So I can speak specifically as it relates to treatment during pregnancy. So during pregnancy, the stage of your syphilis determines how you will be treated. But first-line therapy is penicillin G. So good old-fashioned penicillin. It's an antibiotic that's been around for a long time. It's given as an injection typically for primary and secondary syphilis, and it sometimes has to be given in multiple doses depending on the stage of your syphilis. I'll leave the pediatrics to you, but I do believe for kids it's the same penicillin, but different dosing and different timing of treatment.
I can speak to a little bit about the different scenarios that we see in infants. There's 4 different scenarios that we will typically see. The first is confirmed or highly probable congenital syphilis. And in that case, the infant is definitely treated, typically for about a total of 10 days. Scenario 2 is possible congenital syphilis. And in that case, treatment is usually recommended for 10 days. And there's a lot of different variables that will be evaluated in the infant after birth to kind of help guide treatment, whether it's needed, duration of treatment as well. And that includes looking at their blood, their cerebral spinal fluid, and also doing x-rays of their long bones. So typically the ones like in the legs and the arms. And then there's 2 other scenarios. The third scenario is where it's less likely. Usually in the scenario where it's less likely, we may consider a dose of penicillin for the infant. And typically some follow-up is done in the first 6 months of life. And then the fourth scenario is where it's unlikely. And in the unlikely scenario, no treatment is typically required. So in terms of treatment, how urgent is it? Does catching it early help with avoiding some of those negative outcomes?
Our best recommendation is to test as early as possible and treat effectively as early as possible to avoid transmission to the baby. Whether you have primary, secondary, or tertiary syphilis, there's always a risk that syphilis can be transmitted to the baby prior to delivery, giving the baby congenital syphilis after delivery. If you have been treated, especially treated in a timely fashion, there's less of a chance of transmitting it. And in the instance that it is transmitted, there is always a possibility that the consequences on the baby may be a lot less if you were treated. I would also say that the longer you go without treatment, the higher the risk of having syphilis affect the brain, the spinal cord, the heart, and other major organs. So again, the key is to treat early, and not only treat, but make sure that we're treating effectively with the appropriate dosing of medications in a timely fashion.
Awesome. And what can people do to prevent getting syphilis, whether or not they're pregnant?
So syphilis is a sexually transmitted infection. So by definition, one of the main ways it is transmitted is through sexual contact. There are a few things one can do to protect themselves or at least limit their exposure to syphilis. One is avoiding unprotected sex with individuals you do not know or don't have a relationship with. The next thing is that if in a relationship, having a discussion about appropriate screening and your sexual history and whether or not you've had any sexually transmitted infections and what are they, and if you had, when was the last time you were treated? The other thing is I think sometimes we neglect to tell or to have discussed right on you. I'm not really sure what it is, but I think we need to pause and find out what it is before resuming a sexual relationship. Remember that one of the primary evidence of syphilis is this lesion, this like painless ulcer that can be in the vulvar region. So pause if you see something that doesn't look right, or if your partner is reporting symptoms that are concerning. Barrier methods will not prevent syphilis from spreading, and that's really important to know. Use of barrier preventive measures like condoms, for example, are highly encouraged for decreasing the risk of many sexually transmitted infections. However, there are cases where you could use condoms or other barrier preventive methods and still get illnesses like syphilis. If there's a lesion already on your partner and you are exposed to that lesion, barrier preventive measures will not prevent acquisition of syphilis. And consider getting tested before involving yourself in a sexual relationship. Have an open discussion with your primary care provider about what is appropriate, what screening should be done, and then how can you best also relay that message to your partner so that you both start off knowing what is your status.
Can you get syphilis if your partner does not have any lesions?
Yes, syphilis can be transmitted without having any symptoms. Your partner can be in a latent phase, which is that phase where if they were not tested, they would not know that they have syphilis. You come into contact with them, you have a risk of acquiring syphilis from them as well. But keep in mind, there are times when folks have symptoms, but they just don't know they have symptoms. That painless ulcer can be inside the vagina, for example, or inside their mouth, in the mucous membranes of their mouth. Someone may actually have symptoms, not know they have symptoms, and still transmit it.
All right, cool. This was awesome. Thank you so much for joining us today, Yvonne. I really enjoyed our conversation.
Thanks for inviting me. This was fun.
So the good news is syphilis can be treated. Plain old penicillin cures it. If you're pregnant or you're even thinking about getting pregnant, get tested and know your status. If you test positive, getting treatment as soon as possible decreases the risk of complications for you and your baby. And don't forget about prevention. Syphilis is usually spread through sexual contact, but coming into contact with a lesion on any part of someone's body can transmit it. So barrier prevention methods like condoms don't necessarily protect against syphilis. Remember, people might not have symptoms or might not know they have symptoms. If you're concerned you might have been exposed or do have symptoms, talk to your primary care provider. That's all for this episode, but if you have a question or topic suggestion, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Mayo Clinic Kids episodes and resources, check out our website at mayoclinic.org/kids. Okay, thanks for listening.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.